Hello everyone. Before I start the session, do let me know my voice is clear to you. चैट बॉक्स के थ्रू काइंडली मुझे आप इन्फॉर्म कर दें कि मेरी आवाज़ आप सबको आ रही है.
Yes, sir, you are audible.
Okay, thank you. Now, you all are requested to kindly keep your mic muted, and we are going to start. And before अफ्तारी, I will try कि हम सेशन को जो है वो end up कर सकें. Just a sec. Okay. So before I proceed this session, uh, let me introduce the about the session and about the rehab experts panel. My name is Dr. Dilip Kumar, and I'm founder CMT Center of Mental Therapy and also founder of this project rehab experts panel. इस प्रोजेक्ट का सिर्फ एक ही जो है वो मकसद था कि हम डिफरेंट टॉपिक्स के ऊपर बात करें और डिफरेंट स्पीकर्स या डिफरेंट जो रिहैब से रिलेटेड एक्सपर्ट्स हैं उनको इनवाइट करें और फिर जो भी चीज़ हम प्रेजेंट कर रहे हैं उसको एविडेंट बेस हो. एविडेंट बेस से क्या है मुराद? जैसे कि सामने आपके सामने जो प्रेजेंटेशन होगी इसकी एट द एंड हम आपको जो सर हैं हमें उनका एविडेंस भी प्रोवाइड करेंगे कि भाई ये जो चीज़ें हैं. एविडेंस डजंट मीन कि आपकी किसी प्रेजेंटेशन से डेटा उठाई गई हो. एविडेंस का मकसद होता है कोई भी रिसेंट आर्टिकल, कोई भी अथेंटिक आर्टिकल या कोई भी बुक से डेटा ली गई हो. तो वी वुड लाइक टू थैंक्स टू द सर एज वेल. लेकिन जो भी डेटा होगी वो एट दी एंड. मैं सर को इंट्रोड्यूस कराने से पहले इसका प्रोजेक्ट बता रहा हूँ. ये 10वां सेशन है, 10th सेशन है. मेरा टारगेट था कि हम हर हफ्ते एक सेशन के ऊपर कम से कम बात करें. तो मैं डिफरेंट स्पीकर्स को इनवाइट करता हूँ, उनको जो है वो थैंक्स टू देम कि दे आर ज्वाइनिंग और वो हमें ज्वाइन कर चुके हैं. इसमें नेशनल भी हैं और इंटरनेशनल स्पीकर भी है. तो इस प्लेटफॉर्म का सिर्फ एक ही मकसद है कि जो भी रिहैब रिलेटेड एक्सपर्ट है, कोई भी टॉपिक, कोई भी टेक्निक, आप कोई भी स्कूल ऑफ थॉट के ऊपर आप बात करना चाहते हो, यू आर वेलकम. बस उसका छोटा सा प्रोटोकॉल, आप एक हफ्ता पहले हमें टॉपिक देंगे, हमें ज्वाइन करेंगे, हमें आप डेटा देंगे कि इस टॉपिक के ऊपर मैं बात करना चाह रहा हूँ. और फिर हम देखेंगे कि वो एविडेंस बेस है और आपकी स्किल्स, आपकी काबिलियत उसको मीट करती है. तो यू आर वेलकम, यू कैन ज्वाइन. देयर आर द नो चार्जेस टू ज्वाइन. ये हमने जो 100-200 रुपए चार्जेस रखे हैं, इसका मकसद सिर्फ ये होता है कि जो ऑपरेशनल एक्सपेंसेस हैं उनको मीटअप करने के लिए. आपको पता होगा जूम का वर्जन वगैरह लेना पड़ता है, ये जो छोटे मोटे जो ऑपरेशनल एक्सपेंसेस हैं. और 100-200 मेरे ख्याल से इस तरह के कोई इस तरह के ऐसा चार्जेस नहीं है कि आपको इतने ऐसे टॉपिक. और अगर आपने प्रीवियसली हमारे टॉपिक ज्वाइन करने हैं, यू आर कैन. ये 10वां सेशन है. इससे पहले जो 9 सेशन हो गए वो भी आप ज्वाइन कर सकते हैं अगर आप उनको गो थ्रू कर सकते हैं. उसके भी चार्जेस इतने ही. वेल, नाउ कमिंग टू दिस सेशन. और फर्स्ट ऑफ ऑल आई वुड लाइक टू थैंक्स टू द सर रेस्पेक्टेड डॉक्टर चमन लाल फॉर ज्वाइनिंग अस. इनकी जो एक्सपर्टीज के हवाले से हमने इनको करवाया. पहले मैं सर को मुतारफ करा दूं. सर ने जो है वो 10 to 15 ईयर्स ऑफ मोर देन सर का जो है सिर्फ क्लिनिकल एक्सपीरियंस है. 10 to 15+ ईयर सर का एकेडमिक एक्सपीरियंस है. राइट नाउ सर करंटली जो है वो डीजी खान में एज आईपीडी फिजियोथेरेपिस्ट हैं. और करंटली जो उनकी डिग्री है वो पीएचडी कर रहे हैं लिंकन मलेशिया से. सर की एक्सपर्टीज के हवाले से जो है सर ने जो है वो सर की एक्सपर्टीज ज्यादातर वाबस्ता है इलेक्ट्रिकल और न्यूरोफिजियोलॉजी की तरफ. तो जो ये टॉपिक भी हमने चूज किया हुआ है, एज यू कैन सी, नेविगेटिंग द टूल्स रिगार्डिंग द अंडरस्टैंडिंग द न्यूरोफिजियोलॉजी टेस्ट एज अ फिजियोथेरेपिस्ट फॉर द फिजियोथेरेपिस्ट. तो जो ईएमजी और एनसीएस की टेस्ट होती है जिनको हम बेसिकली रीड नहीं कर पा रहे, सर की उनकी उनमें जो एक्सपर्टीज है. तो सर हमें बेसिकली ये सिखाएंगे कि एज अ फिजियोथेरेपिस्ट हमने किन किन चीजों को देखना चाहिए या उनसे. हम तो नॉर्मली एनसीएस और ये जो ईएमजी की रिपोर्ट्स हैं उनकी डायरेक्टली कंक्लूसिव रिपोर्ट तक पहुंचते हैं कि कंक्लूजन क्या है. हम सबको पता है एनसीएस हम क्यों कराते हैं. अगर किसी में नर्व इंजरीज हैं वहां पर रिकमेंड करते हैं. अगर मसल्स की इलेक्ट्रिकल इम्पल्सेस हमने चेक करने था ईएमजी रिकमेंड करते हैं. हमें हार्डली इतना पता होता. तो एज अ फिजियोथेरेपिस्ट इनकी क्या इंपॉर्टेंस है, सर इनके ऊपर बेहतर हमें गाइड कर सकते हैं, बेहतर हमें बताएंगे. तो फर्स्ट ऑफ ऑल आई वुड लाइक टू थैंक टू सर चमन लाल जो कि एज अ फिजियोथेरेपिस्ट इनका इतना एक्सपीरियंस और ये सर्व कर रहे हैं डीजी खान की तरफ. बेसिकली सर जो प्रैक्टिकल क्लिनिकली प्रैक्टिस कर रहे हैं वो मुल्तान से बिलोंग करते हैं, मुल्तान में प्रैक्टिस कर रहे हैं. तो सर फर्स्ट ऑफ ऑल थैंक यू फॉर ज्वाइनिंग एंड डू लेट मी नो सर माय वॉइस इज क्लियर टू यू. एंड आप भी सर हमसे बात करें फिर मैं सेशन का आगाज करता हूँ. तो सर आप हमें बताएंगे कि आप कैन यू हेयर मी एज वेल. मैं आपको सर
Yes,
अनम्यूट.
sir. Thank you. Good evening, Dr. Dilip, for the session and inviting me. Yeah, I can hear you.
ओके, थैंक यू सर. अब बस मैं आपका 1 मिनट लूंगा और उसके बाद सर इट्स ओवर टू यू. अच्छा सर, मैं बच्चों को ये बताना चाहूंगा कि सेशन का एक और मकसद भी है. एट द एंड जो भी बच्चे के सवाल पूछे जाएंगे वो आप लोगों ने चैट बॉक्स के थ्रू पूछना है. किसी ने भी माइक को अपने जो है वो अनम्यूट नहीं करना। आप अपने क्वेश्चंस बताएं एट द एंड, शुरू में पूछें, एंड पूछें, हमारी टीम नोट डाउन करेगी। इस प्लेटफॉर्म का एक और मकसद भी है रिएब एक्सपर्ट्स पैनल का, कि 10 क्वेश्चंस कम से कम हम जो रेस्पेक्टेड स्पीकर होता है उनसे पूछते हैं, और उनमें से 5 पैनलिस्ट की तरफ से होते हैं और 5 क्वेश्चन जो है ऑडियंस की तरफ से होते हैं। तो आप में से जिसका भी क्वेश्चन होगा वो नोट डाउन करके चैट बॉक्स में हमें बता दें, हमारी टीम उनको नोट डाउन करेगी, और एट दी एंड हम सर से पूछेंगे और उनके जवाब लेंगे। अब मैं मजीद सर को, सर नाउ इट्स ओवर टू यू, और आप डील करें। मैं आपके साथ रहूंगा सर, जहां पर आपने स्लाइड चेंज करनी हो आपने सिर्फ नेक्स्ट बोलते जाना है, माय टीम विल डील विद देम, और जो आपकी जो दो वीडियोस भी हैं वो भी इंशाल्लाह प्रेजेंट करेंगे। सो नाउ इट्स ओवर।
Now you can hear me? Okay, thank you, Dr. Deep and CMT team. Good evening and greetings to all the participants over here. Uh, Dr. Deep ने तारुफ करवा दिया. My name is Dr. Chaman Lal. I am practicing in Multan. Neurophysiology is my area of practice for the last 15 to 16 years. I shall here share some clinical guidelines and the clinical expertise to read the NCS EMG for the physiotherapist. And this physiotherapy field, as we deal with the routine patients, often miss the clinical interpretations of the different tests which are directly related to us and which should be known to us, like the clinical neurophysiology procedure, as we are going to discuss here. First of all, I shall request to play the presentation, please. Thank you, sir. Kindly next. These are the outlines which will be discussed in this our presentation. Next, please. So, as regard with the neurophysiology, I will discuss with respect to the physiotherapist that the clinical neurophysiology is a vital field that bridges the gap between the diagnosis and the therapeutic interventions for physiotherapists. As we deal with the patients, we deal with their conditions, and we see that this field bridges the gap between the diagnosis and the therapeutic interventions. That if the patient is suffering from nerve disease, nerve injury, muscle disease, or the muscular injury, then how we have to respond to the treatment to that patient, and how the plan should be redesigned for the appropriate treatment measures for faster results. So, by understanding the electrical activities of the nervous system, physiotherapists can accurately diagnose conditions affecting neuromuscular functions and the tailored treatment plans effectively. Key focus areas include the electromyography for assessing muscle activity, nerve connection study for evaluating the nerve function, and EEG for brain activity monitoring. Evoke potential studies like the ABR, BERA, VP, SSCP, study for the hearing, vision, and the peripheral dorsal columns metasensory pathway monitoring. We will discuss later on one by one on these topics. And our main topic will be the nerve connection study and EMG, which is very helpful. And we can say, I usually say it, stage play means you do the procedure and you get the at once results, and then you revise your planning for the patient, that what treatment plan will be suitable for that patient. If the disease is at the mild, moderate, or the serious stage, then you should have to revise the plan accordingly. So, the neurophysiology is a science of medical specialty that studies the central and the peripheral nervous systems through the recording of the bioelectrical activity, whether spontaneous or the stimulated. So, here, as we have used the terms spontaneous, next slide, please. Yeah, thank you. As we have stated this spontaneous or the stimulated activity, the bioelectrical signals are gathered with the help of the differential amplifier to be studied. As we see that our body is, we can say, it is made up of electrical circuit that is in the form of the electrical nerves, our nervous system and the peripheral system, which conducts the impulses through its nerves and into the muscles, which are the effector organ. So we can record these. And some of the activities are spontaneous, like brain activity, and some are to be stimulated with the help of external source, like as we do some reflex testing, like synaptic reflex, we say the corneal reflex or the knee jerk, etc. These are the stimulated reflexes or the stimulated potentials which we see in the response to the body nervous system stimulation. So these are the stimulated responses. So both spontaneous and the stimulated can be recorded nowadays as the advancement of the we can say the technology. So these signals are very microvolt signals. These are recorded through the oscilloscope and are represented through the different representation of the waveform, and we interpret that is it is a normal or a not. So first of all, we have to define what is a biological signal. Any electrical activity that is being generated or being stimulated through the nerves in the body is a bioelectrical signal. Like we record the ECG, that is a electrical activity of the heart. Same likewise the EEG, electrical activity of the brain. Likewise, the NCS nerve connection study is an electrical activity of your nerves, which are recorded from the surface of the your skin or the through the muscle belly. So next slide, please. So what makes nerve cell excitable? These are the neurotransmitters. These work through one synaptic knob to another synaptic knob, and we get the end product in the form of electrical activity, which is collected through the we can say these are the head box which collect the electrical signals and amplify to show that minor signal into the bigger screen, and we recognize this as a bioelectrical potential. So the spontaneous electrical activity, as we stated earlier, that is the EEG or the visual evoked potential. And then establishment of the membrane potential. As we know, the membrane physiology, the outside is negative and the inside is positive. And when there is a shuffling of the membrane potential, then there is a generation of the active action potential. So the generation of the action potential and the saltatory condition, it will be discussed in the later slide as well. This is generated through the some appropriate amount of the signal which is given to that nerve, and it stimulated and give the electrical potential. And when it is recorded, then we can interpret into its with regard to the normal data that either it is a normal or abnormal, and what are the normal parameters, we will discuss it as well. So we know that electrical activity transmit through one node of anywhere to the another node of anywhere, and uh, dendrites are the receiver, axon is the carrier, and then the synaptic button is again deliver to the next synaptic junction or the neuromuscular junction. So at the end, the signal is communicated from forward direction, as we see in the nerve potential, while in the muscles it travels in the both directions. While in the nerve, it's only propagate in the forward direction, or we can say in the unidirection way, from dendrite to the synaptic knob. And then we will see these are the some abbreviations which are please next slide on. Yeah, these are some abbreviations that can be helpful for the your some exams or some sort of we can say uh, extra knowledge. When we study the different books, we use these abbreviations, and especially in the neurophysiology, you encounter with these abbreviations. We will just go through these. Please, next slide. You can read them later. Main important will be discussed during the our interpretation as well. So, just coming back to our neurophysiological nervous system disciplines, that neurophysiology disciplines are mentioned here. First is EMG and NCS. Next one is a BEAR. We also called it as a ABR test or the BARA test, brainstem evoked auditory response. somatosensory evoked potential SSEP, TMS, then NIOM, intraoperative monitoring, TMS is cranial muscle stimulation, SPSG, VP, and EEG. So, just this is electroencephalogram, that is electrical activity of the brain that can be recorded through the electrode, and that is a simple just for your increase of the knowledge, addition of the knowledge that the EEG electrode are placed according to 1020 system international of electrode placement, and we record the electrical activity. So I will add the question, add the sentence here that what is electrical potential? Electrical potential, or we can say potential difference, is activity that is generated between the two sources. Either these are the positive, either these are the negative, either these are it is one is a positive, one is a negative, or one is a negative, another is a positive. That is a potential difference which is created between the two potential sources, and we read as a electrical signal. So signal cannot be a single one. One should be a reference and one should be in an active site of the electrical potential. And when we reference that electrode to the another one, then we get the potential difference, or we can record the potential that is studied in our different labs. So next slide, please. So in EEG, there are the different waves. You can see the alpha, beta, theta, and delta. These might be helpful for some exam preparations or some your increase in your knowledge. That when we say that it is alpha activity, it is 8 to 13 hertz activity. Hertz mean a unit second activity. Means alpha waves come 8 to 13 hertz in a unit second. Likewise, the beta activity 13 to 15, 35, and theta 4 to 7.5 hertz in a second, and then zero point 0.5 to 3.5 is a delta activity. So these are the different activities which are recorded in the EEG activity. This is a EEG diagram which is on the screen, and when you will see that the larger amplitude waves, these are the alpha waves, and you can count in a second. These will be around between 8 to 10 or 8 to 13, and on the frontal side these are the beta activities. This is a normal awake eyes closed EEG tracing being shown here, just for to know that electrical activity of brain is represented over the graph like this as we are seeing here. So next please. So next is our important electromyography and nerve connection study. So when we will in the previous slide, we see the EEG, where the EEG is recommended, and when we have to ask the patient to get an EEG. So for the physiotherapist, as we are not the primary physician for the patient's this epileptic condition or brain-related condition, but we can suggest that if the patient is suffering from migraine, the patient is suffering from some dizziness, patient is suffering from dementia, and the patient is having vertigo, and patient is having some sort of seizures, and the appropriate guidance is not available, then definitely a physiotherapist, being a medical professional and know the pathophysiology of the CNS as well, so he should ask or request the patient to get an EEG, so that later on it might be get checked to the neurophysician for an appropriate treatment. So by our understanding, we should know that why the EEG is done. EEG is done for abnormal activity, abnormal firing of the brain that results into the fits, or that could result into the migraine, or that could be due to the SOL space occupying lesions, or the deep seated tumors that pulsate and did the dizziness, vertigo, balance dysfunction, or diplopia, or other abnormal activities in the brain that are being transmitted to the body's system, and that can be read through the physical examination, or the patient itself describe these conditions, so therapist can help that patient for appropriate test. So as we are discussing the electromyograph and the nerve connection studies, it is our area of study and area of practice as well. And as we have listened from our teachers and taught from our teachers that anatomy and physiology should be on the fingertips of the physiotherapist so that he might be able to grab the condition of the patient to treat it effectively. So, in electromyography, we have to study the electrical activity of the muscles, and in nerve connection, we have to study the different characteristics and the different nature of the nerves. So electromyography is the study of the motor unit potentials via the disposable or the surface electrode, either through the spontaneously or through the muscle activation procedure. While the nerve connection, we can record the sensory nerve signals from the skin, and from the muscle belly, we record the compound muscle action potential. We also call this as CMAP, while the sensory nerve action potential is abbreviated as SNAP. So both tests are studied together to final conclusion or the diagnosis of the neuromuscular disease process. Next, please. So here you can see on the left side there is a nerve connection test being conducted on a patient, and on the other hand, you can see the disposable needle electrode as it is connected to the screen and the computer. It record the electrical activity of the muscle, and it is invasive procedure, and precaution should be taken which are universal and the standard as well. The surface should be clean, hygiene, and protective measures should be adopted that to the examiner who is going to conduct this test. Next, please. Okay, by the definition, EMG is a diagnostic technique that measures the electrical activity of muscle during the rest and the contraction. And in this, what is the purpose in physiotherapy? As we can access the neuromuscular function, muscle activation, and the nerve conduction. It helps the diagnosis of the neuropathies, myopathies, and the motor control disorders, guides rehabilitation and the biofeedback training. And biofeedback training is utmost necessary for rehabilitation purpose. And there are the two types of the EMG which can be done. One is the surface EMG, that is a non-invasive. It is the same like we apply the electrode, a TENS or the EMS electrode over the muscles and record onto the computer. That is a surface electrode EMG, surface EMG. And another one is a needle EMG that we have seen in the previous slide. That is invasive, provides the detailed muscle and the nerve function analysis. And we should learn the detail as well, that if we are going to insert a needle, then how the pattern will become on the resting condition and on the muscle recruitment. And on the surface EMG, when we are using the surface electrode, what will be the behavior of that EEG activity. So clinical application will be that if we apply the surface EMG or the needle EMG, then it will identify the muscular weakness that causes, it could be the neurological or the muscular. Muscular is like direct injury to the muscle, or neurological that we say the indirect injury that is coming from the nerve and then it is affecting the muscle. Then it can evaluate the spasticity, muscle fatigue, and the coordination as well. And it will assist in the post-stroke spinal cord injury and the sports rehab. And it is important task when we are dealing with the such patients rehabilitation, and we are not aware of the stage of healing, because first there is a physical appearance of the activity and the neurophysiological activity comes later. At least it takes 6 to 8 weeks or beyond that time as well. So, while interpreting these signals, we can state it as a normal resting state, minimal activity, or the mild activation state, that is a small or the less recruitment potentials. The muscle is not activating fully, as we see in the MMT, that is a gross testing of the muscle activity with the naked eye, and we do it with the help of our resistance. And while this is a more accurate and a more refined method of muscle testing through the surface electrode or through the needle electrode. So full contraction, it will represent the full synchronized potential. And abnormal finding could be there will be the no activity at all, there will be the neuropathic motor unit finding, or there must be the myopathic motor finding, and the positive shower waves, fibrillation potentials, which shows the sign of nerve injury. And these will potentials will come out spontaneously when we insert the needle, and the abnormal activity represent you that there is a nerve injury process which is being represented into the muscles as well. So polyphagic waves, if coming on the needle, that representing that the nerve is in the healing state. So that are the helpful hints that we can assess that the patient is in the third week of injury, and coming the polyphagic waves that the nerve is going to be healed and our therapy is responding, and it is a good conclusion that we can um, give the therapy more energetically, so that the healing should be appropriately up to mark and according to the time limit as we predict 4 to 6 weeks of a nerve injury. And limitation are that it requires the trained interpretation, and surface EMG cannot isolate the deep muscles because we studied the gross muscles on the surface EMG, and needle EMG may be cause some discomfort because needle irritate the muscles, and that causes the pain, and some patients report very discomfort on this needle EMG activity recording. So integration with the physiotherapy, use of the muscle re-education, postural training, and neuro rehabilitation, the EMG and nerve connection studies plays its vital role and established a great advancement of treatment approach if it helps to tailor the exercise program for neuromuscular condition. So EMG is a valuable tool for the physiotherapist, aiding in the diagnosis, rehabilitation, and the treatment planning of the neuromuscular disorders. So next, please. So we have the patient. Uh, Next slide, please. Okay, it is a patient of the post stroke rehabilitation. As we can see that the therapist is re-educating to extend the wrist, and the muscles being studies are the EIP and the wrist extensors mainly, and EMG activity give the positive feedback, and the patient willingly do the more effort to generate the extra potentials. And when these action potentials are generated, it means that the communication is coming from the higher mental function, that is a higher brain cortex, that is our motor cortex located into the frontal lobe, and that activity is coming from the first order neuron, then it is translated into the second order neuron and executing at the third order neuron, that are the peripheral nervous system neurons, and the muscles are being activated through this intricate and communicated network of this potential. And that is a very effective activity which is being uh, just being generated through the command rather than the passive mobilization or the passive activity. And when we do this, the early recruitment of the muscles facilitate the early rehabilitation and early recovery. And it is a very good sign that patient is able to extend it with its active motion, active exercise. And next, please. So that results into the we can say surface EMG feedback mechanism. Please play this activity. This is surface needle
लगाए जोर लगाए कोशिश करें ठीक है ढीला छोड़ दें
this is a needle electrode activity which is being recorded here, and kindly play this EMG activity. So we can say this is a baseline which is being represented over here, and when we will play, you can see the recruitment of potentials with voice, please.
लगाए जोर लगाए कोशिश करें ठीक है ढीला छोड़ दें
So you can see that the compound muscle action potentials, which are studied on the nerve connection study, can be seen on this monitor screen with the help of we can say, our machine. And electrical activity, this activity is being recorded and studied in this condition. And
Yes, sir.
yeah,
May
sure.
I continue?
Yeah, sure.
Continue.
Thank you. Thank you. Next slide, please. Okay. In this EMG finding slide, normal, reduce, increase, and some normal and abnormal discharges are being displayed with their durations that can be might of some interest to the learners who want to read the EMG, how the signals is being read. And when we put the needle, it is called as the insertional activity. And then we see the spontaneous activity, and then motor unit potentials are recorded on activation of muscle. And then recruitment interference pattern is labeled as normal, abnormal, or we can say neuropathic, myopathic, or the normal. So when it is coming in a less frequent way, then a single unit fire repeatedly. When these are less and a single unit will fire it repeatedly, then it is called as rapid firing, and it is seen in the neuropathic condition. And when muscle units are small and these are being recruited early and very fastly, then we say that these are the myopathic potentials, small reduced muscle potentials, and it is seen in the myopathic condition. And when full screen is being observed, then we say that it is a normal recruitment potential with 3 to 4 turns from baseline, and it is a normal morphology, and we labeled it as a normal healthy motor unit. And when we see more than 4 to 5 turns of a unit on a screen, then we say that it is a polyphasic unit. When we see that it is a polyphasic unit, we say that polyphasic unit is a sign of nerve recovery, which is being seen on the EMG. So it is a helpful sign for the physician and the therapist that nerve is in healing phase and being recorded as well. Next slide, please. Okay, we will go through the membrane potential as we discussed earlier. The resting membrane potential refers to the -62, -85, or the -70 millivolt, with the net negative inside the membrane and the positive outside the membrane. The membrane potential results from the separation of the charge across the cell membrane, results from the unequal distribution of the intracellular and the extracellular ions. As we see the electrical potential, electrolytes, sodium, potassium, chlorine, and then is a negative ion, which are distributed unequally into the negative in the outer and the inner surface of the membrane, which gives its resting condition. And when we disturb this resting condition, then there is opening of the sodium potassium pump, which results into the disturbance of the membrane potential. And if this threshold is sufficient, it will generate a potential which will give you the rise of the action potential, which can be interpreted and recorded. And when it's sufficient to record, then we can interpret this. Next, please. So just play this slide if we can see.
An action potential arrives at the presynaptic terminal, causing voltage-gated calcium ion channels to open, increasing the calcium ion permeability of the presynaptic terminal cell membrane. Calcium ions enter the presynaptic terminal and cause vesicles to release their neurotransmitter acetylcholine from the synaptic vesicles into the presynaptic cleft. Diffusion of acetylcholine across the synaptic cleft and binding of acetylcholine to acetylcholine receptors on the postsynaptic muscle fiber membrane causes an increase in the permeability of ligand-gated sodium ion channels. The movement of sodium ions into the muscle cell results in depolarization of the postsynaptic membrane. Once threshold has been reached, a postsynaptic action potential is generated and is propagated over the muscle cell membrane. Acetylcholine is rapidly broken down to acetic acid and choline in the synaptic cleft by the enzyme acetylcholinesterase. The choline is reabsorbed by the presynaptic terminal and combined with acetic acid to form more acetylcholine, which enters the synaptic vesicles.
I have to. Okay. When we see that when the electrical potential come down to the synaptic knob, this is a neuromuscular junction, and we can see the receptors over here. Two receptors are being represented on the postsynaptic membrane, and the presynaptic membrane is when excited, the nerve action potential is generated, and the calcium channels are open, and calcium this dip down into the membrane, and the acetylcholine is released, which is binding on the active sites. And when the active sites are filled with this, these open the sodium potassium pump, and there is an influx of the sodium ion, and which changes the postsynaptic membrane potential, and this gradient results into the action potential generation. So acetylcholine is then broken down by the acetylcholine esterase into the acetyl and the acetate. Acetate is then degraded, and acetyl part is reabsorbed to make the new acetylcholine. And when we see that it is an excitatory synaptic knob, the vesicles will be rounded, and when we'll see the inhibitory, that will be some oval shape. So there is a 200 to 300 strong functional gap between the pre and the post synaptic membrane, and therefore it is called as the functional gap. It is not the synaptic knob directly touches the post synaptic membrane. There is some gap, there is some gutter, which that we can say that it is a functional gap, functional junction. And when the acetylcholine is transmitted into that medium, then it excited the acetylcholine receptors, and then the binding of these acetylcholine will accelerate the action potential, and the impulse which is coming from neuron is then transmitted to the neuromuscular junction muscle potential, muscle membrane, and then muscle membrane. As we discussed, in the neuron it is a unidirectional flow of the electrical impulse, while in the muscle it is a directional flow of the electrical impulse. So the impulse will be directed on the both side of the membrane of the postsynaptic membrane, and then the action potential is generated on the postsynaptic membrane, which results into the muscle contraction, and that is recorded on the oscilloscope and being studied on the monitor as well. Next slide, please. that is a neuromuscular junction anatomy. And when we see that in the myelinating neurons, there is a thick myelination and which responsible for the fastest conduction of the nerve impulse. So the nerve impulse is directed in the forward direction from one node of anywhere to the another node of anywhere in the propagation manner, saltatory and jumping manner. Therefore, it is called as the saltatory propagation of the action potential, and that results into the fastest conducting potential. Or when we see that the demyelinating neuron, it faces the lot of hindrances, therefore the potential is not as fast as seen in the myelinating neurons. Next, please. So when we sufficiently stimulate the neuron nerve fiber and record it from muscle, then we can see that we have generated an action potential. So zero is a baseline, and when we give the stimulus to the patient, then a rise phase is seen of the action potential, that is called as the depolarization phase, and then the maximum peak potential is reached, that is can be labeled as a peak potential, and it will be helpful when we will count for an amplitude, that is a vertical distance from base to peak of that potential, and then after that. At this point, the maximum influx of the sodium occurs across the membrane, and then the channels are closed, and then the negative, then there will be reversal of the potential, that is called as the repolarization phase, and then the sodium will be pumped out through the these sodium potassium pump, and we will see that the repolarization phase, the baseline potential is being reached. But after that, as due to some leakage potential, there is excessive invasion of the sodium ions, which results into the hyperpolarization phase that we seen as a after potential. While after this, all the channels will be closed and sodium will be pumped out, and this resting potential will be will be reassured again. And when we record this potential, when we will see that there is a depolarization phase, there is a peak potential phase, then repolarization and hyperpolarization phase, and then again the resting potential will be reached after some time when the sodium potassium pump will actively uh, kick out all the sodium to outside, and negative balance will be maintained inside the membrane. So it is done at cost of ATP. So it is an energy expenditure process. Next slide, please. We will discuss this action potential next. Here is just some glimpse of the nerve connection study. Sorry, previous. Yes, in this slide, that is a placement of active recording electrode on the surface of skin and muscle belly as well. When we place electrode on the muscle to record the nerve action potential, then this method is called as the belly tendon method. We place the electrode on the muscle belly, which is a maximum bulky point of the muscle, and then place the reference electrode further from its belly point at its likely the insertion place. In this, median nerve is being studied, and we can see on the thumb side, black electrode is placed on the thenar eminence, and the reference red is placed on the first MCP joint, that is APB muscle reference point, and we stimulate this nerve from the median main path, and second stimulation will be done on the cubital uh, point, that is a in the front of our elbow, and third point can be stimulated from the axilla as well. So this in this condition, median nerve be activated, stimulated, and being recorded on this APB muscle, and hence we say that that is a compound muscle action potential. While we are discussing with the sensory nerves are recorded on the surface. So we have the digital branches, so that can be recorded on the surface, and we should know the neuroanatomy of that nerve, and we can record the action potential of any nerve which give the cutaneous distribution to the skin. As we know that medial half of the our hand is distributed by ulnar nerve, while the lateral 3.5 is distributed by the median nerve, while the dorsum of the hand is supplied by the radial nerve, except the dorsal ulnar cutaneous fourth web space. And then same likewise, we have a lateral border of our, we can say, the arm is supplied by the radial sensory nerve, or then the medial side is supplied by the ulnar nerve, and then a medial cutaneous nerve of arm. So these are some different points of the hand and the skin that are being studied to record the sensory and action potentials of our median nerve. And we can record the peripheral nerve like the median, ulnar, radial, musculocutaneous. Then uh, in the lower limb, we can record tibial, peroneal, major motor nerve, then femoral nerve, and like in the sensory upper limb, we can record all digital branches of the hand. We can record dorsal ulnar cutaneous. We can record radial sensory. We can record lateral antebrachial. We can record medial antebrachial, which are very helpful in the diagnosis of brachial plexus injury, isolated nerve injury, like the mononeuropathies. So we can isolate these nerves and we can record and can conclude that which nerve is affected in that its course or path. So in the lower limb, we can record the saphenous nerve, sensory. We can record the sural nerve. We can record peroneal nerve, superficial peroneal nerve. Next, please. So here is some picture of action potential. We will go through it as we have studied in our I think fourth or final year, when we studied the chronexy and other nerve action potential details. So when we record action potential, it has some specific characteristics. Uh, Consider the dotted baseline and x and y axis. So when we give the stimulus with the specific distance, it will give the initial deflection, either upward or downward. It will be the first deflection. And here we give the cut mark as a latency. So latency is the time period to give the response after the stimulation arrived at the muscle point, and it gives the deflection. So latency is a time period taken to initiate a response of a nerve collected through the muscle. So latency will be this. This is called as the distal latency, as it is a first latency we are being recorded at as we see in the previous picture. The electrode are placed on the thumb. Therefore, we say that it is on the thumb side, and it is a wrist point that we are stimulating. Therefore, it will be the distal point. And when we will stimulate through the elbow, that will be the proximal, because we are coming towards our head side. Therefore, it will be proximal. So next signal will be the proximal latency. Then we said that it is a maximum peak, and after potential to maximum peak, that is a base to peak. When we will see the base to peak, it will be calculated as an amplitude. And then the baseline is coming from this after potential, and after wrist potential, we record the elbow potential. The elbow potential is same of height, but it will be further away in the latency, because it is coming from the elbow side, and recording side is the same, that is at the abductor pollicis brevis muscle, while wrist and elbow both are different places where we have give the stimulus and record at the fixed APB muscle point. So we minus the difference of the uh, distal and proximal latency, and then nerve conduction velocity can be calculated as it is seen as MCV, motor connection velocity, is equal to distance that was L2 minus L1, and divided by the L2 minus L1 latency. So here we can say the both latency differences are minus, and then we can record the nerve connection velocity, which is different in sensory and motor potential, we will see in the next slide what are the normative data of this motor and the sensory one. But with this, as we say that the latency represents the myelination and the amplitude represents the axonal activation. So for the physiotherapist, these two things are important. One is the latency, which is representing the amplitude demyelination or the myelination, while the amplitude is representing the maximal axonal activation. So in the next slide we will see, uh, up to that slide we have concluded the nerve connection study. We will discuss the data, normative data in the last, and we have represented the two cases as well. So another neurophysiological discipline test is a brainstem evoke response audiometry, that is for the hearing threshold, and that can be done in the pituitary tumor, in the ear deafness, in the tinnitus, and in the hearing threshold, neonatal screening. So this brainstem evoke response audiometry is helpful in the assessment of the eighth cranial nerve. And you know that the eighth cranial nerve is responsible for the balance and the coordination as well. So this test helpfully uh, conclude the significance of cranial nerve testing as well with this study. So next please, and these are the specific generators which are represented, and this is a test which is conducted on the one side of the ear, and you can see the latency is being titrated. Maximum auditory stimulus is given at 105 and it is reduced to just 5 decibel. That is a normal range, and you can see there is a slope of potentials being generated on the each reduced auditory stimulus, that representing the healthy air. Next please. So in rehabilitation, we have to see patients which are not responding to treatment, and we should at least assume that the patient is listening to us or not. So if there is some issue in their hearing, then this test can be helpful for the patient for the early diagnosing this hearing evaluation, and the patient will be benefited with this test. And in most of the condition, we usually see the children with these poor school performing and not learning due to this issue of the being the hearing deficit. And when it's rule out, that can be helpful with the aid of hearing aid. The hearing can be increased, and rehabilitation purpose is meet with this condition as well. So now we have a visual evoked potential. This is representation of single eye and the double eye checkup. That is a stimulated potential with the pattern reversal, that is a checkerboard, which is act as stimulating the eye, catching the eye, and then we see that there is a potential generation into the retina of the eye, and at the cranial cortex we record this potential as a inverted V shape, or the VEP, visual evoked potential, and its latency should be 100 millisecond. And when latency is prolonged, we can conclude that the optic pathway is optic nerve is not in good condition, and therefore the patient can be referred for eye checkup and its optic nerve testing as well. Next please. So next one is a somatosensory evoked potential study. That is a main important when we have to see the brachial plexus injury, then we can record from the cervical and the cortex region as well. Dorsal column study is much better with this somatosensory evoked potentials, and it is very helpful in the spinal cord surgeries. And when we do the scoliosis surgery, tumor surgery, then somatosensory evoked potential study is very vital. It record the potential when the surgeon is being operate the spinal cord. So this will help to reduce the chances of the injury. And somatosensory evoked potential is useful in assessment of the dorsal column nerves. Next, please. Okay, on the screen you can see that we have the sensory and the motor nerves, and that is a normative data on the specific distance. Like in adult, median, ulnar, and radial and the sural are recorded, and they are recorded with the 14 centimeter distance, and the distal latency, amplitude, and nerve connection velocity should be in this range. That distal latency and the amplitude and the NCV representing the minimum of the criteria. If amplitude is greater, then it will be well fortunate for the patient that amplitude are much higher than the normative, and latency should be as minimal possible, because it is the final range 3.5. Beyond 3.5 it will be abnormal, so amplitude beyond 10 will be greater, and likewise nerve connection velocity greater than 40 will be appropriate or a good one. So you can see the motor data. So in the motor nerve, we can study the median, ulnar, radial, tibial, peroneal, and peroneal EDB, and tibial as well, peroneal TA as well. So this normative data can represents the normative value. Distal latency should be less than these values. Amplitude should be equal or greater than these numbers, and nerve connection velocity should be greater than these values, and F latency should be less than the given values. So when we study a nerve action potential, we focus on the two things. One is a latency, another is amplitude. Latency should be less than the normative data. Amplitude should be greater than the normative data. Next, please. So physiotherapists should focus on these 2 points. What is the latency and what is amplitude? Because latency representing the myelination and amplitude representing the motor axonal contribution and activation of that axon. So latency should be less than the cut value, and motor amplitude should be greater than the cut values. So here is a case study: a 40-year female housewife having the bilateral pain in the hand, especially at the night, which aggravated by the activities for the last 3-4 months. Other labs are normal, non-diabetic patient, and NCS test advice for the bilateral upper limb. Here you can see with the reference to the normative data, if I can read, then while we are studying the normative data, where NCS nerve connection study, we should also consider side to side as well, because side to side symmetry is also required. And when you do not remember the normative data, it's okay, just compare the right side with the another one. If both are prolonged, then it is something else. But if one side is affected and another one is a normal, consider the normal one as a standard and then compare the other affected side. Then you compare that with reference to your non-affected side, how much affected the nerve or the latency is being presented in that patient. In here, this patient left median is prolonged, amplitude or normal, NCV is normal. Ulnar is bilateral, normal, symmetrical, while the right median is also prolonged, amplitude or normal, symmetrical, and connection velocity is normal as well. F latency is normal in all waves. Next slide, please. So in this slide, I will conclude that bilateral median nerve latency is prolonged, amplitude or normal, and connection velocity is normal as well. Ulnar nerve motor bilateral symmetrical, latency, amplitude, and connection velocity. So abnormality was bilateral prolongation of the motor nerve, bilateral median motor nerve. And in the next slide, as we are seeing the digital nerves that are the sensory nerves, we can see that we have 5 digits. One is supplied by the median nerve, second is supplied by the median nerve, then third is supplied by the median nerve, fourth half is supplied by the median nerve, fourth half is supplied by the ulnar, and then little finger is supplied by the ulnar. So as we see in this, median potentials are prolonged, amplitude are low, and latency connection velocity is slow. So concluding this, next slide, please. You can later on access this as well, and you will see. Next slide, please. Interpretation, yes. Interpretation, you can see that as I have shared that the bilateral median nerve connection showed prolonged latencies, normal amplitude and connection velocities, while the ulnar nerve was plumb normal in amplitude, latencies and connection velocities, and bilateral median F2 and F4 was prolonged, low amplitude, slow connection. So according to this, we can conclude that as the motor nerve is also involved, So it is a bilateral moderate median mononeuropathy at risk, likely bilateral moderate CTS. So with this, we can conclude that is the patient is in the moderate condition of its disease, and it can be conservatively measured, and it can be conservatively treated as well. So with the help of this nerve connection, you can comprehensively manage this condition, and you know the stage of disease as well, and can explain to the patient that your condition is at moderate level, which can be dealt conservatively, and you should focus more on the median nerve pathology across the wrist, rather than to do the another exercises for the other limb nerves. You should focus on that median nerve recovery, and it will yield much better when you will know that condition, and it is presenting your expertise that you are very good grip with that patient condition. So another case history is a 6-year female kid having toe walking, and NCS was advised to check the bilateral lower limbs. That was, you can say that a normal assessment, or that we can find some abnormality as well. So we have this. There are the 36 microvolt sensory nerve is bilateral normal, symmetrical in latency, amplitude, and connection velocity. Next, please. So tibial nerve and peroneal nerve. Next, please. Yes. You can see the tibial and peroneal bilateral are normal. You can compare the latency, amplitude, side to side, and then connection velocity as well. So I have done this study. So I am representing this that both sides are normal in latency, amplitude, and connection velocities. This is a tibial nerve. Next, please. Okay. That is a peroneal nerve. You can compare the latency, then amplitude, and then connection velocity. So these are normal as well. So we can conclude that this is a next slide, please. Interpretation is written over here that bilateral tibial and peroneal are normal. Bilateral sural are normal. EMG was not done due to the technical reason. That could be the limitation as well. And we say that saw that this is a normal limited electroneurophysiology study, and both side nerves are symmetrical and normal. There is no abnormality found, and toe walking can be assessed. That could be due to the some pathology, but in here, in this case, we find that our lower limb nerve are plumb normal. There is no abnormality found. So these are the two cases. Next, please. So this is our concluding slide that physiotherapists play a crucial role in clinical neurophysiology by specializing in EMG and NCS. This expertise enables them to assess the neuromuscular functional comprehensively, which is vital for planning effective rehabilitation strategies. Advanced training and certifications are essential. Definitely, we should know from where we can learn these techniques to excel our expertise and skills, and that is under the domain of the physiotherapist, that they can learn EMG and NCS for their patients and excel their expertise in treating these conditions of the musculoskeletal disorders and the neuropathies and radiculopathies, and this will thus enhancing the precision of the treatment plans. And it is very necessary that you see the result of your treatment on the screen, and then you can devise your plan for the refinement of your plan as well for the patient, and that will reduce the cost, that will reduce the patient efforts, your efforts as well. Next, please. Thank you. These are the references, and next slide, please. Thank you, audience, for having this session. I am concluded with this. I will hand over the mic to the Dr. Dilip. Thank you.
ओके सर, थैंक यू सो मच सर, थैंक यू सो मच सर. सर कुछ क्वेश्चन सर जो ऑडियंस की तरफ से और पैनलिस्ट की तरफ से हैं, कि
Yeah,
अगर
sure.
सर हम किन कंडीशंस में ज्यादातर ईएमजी वगैरह हम प्रिस्क्राइब कर सकते हैं, और दूसरा क्या ये हमारे डोमेन में है कि हम उनको प्रिस्क्राइब करें?
Yes, according to the rehab specialist, you can advise this test, and the basic purpose of this session was to let the physiotherapists know that they can advise these tests, and they should know the protocol, which protocol we have to give for a test. Like you have a patient of the neuropathy, then you should write for the assessment of the neuropathic condition. If you are sure or you are having some differential, then you can put the query with that. Like you are feeling like diabetic neuropathy, then you can question mark the diabetic neuropathy assessment. Then the test performer will comprehensively check this condition beyond other findings as well. So it is well in the domain of the physiotherapist field. And in America, out of 54 states, in 52 states, the physiotherapist eligible to do the EMG and NCS if he gets the sufficient training and hands-on with certification. He can perform these tests for his patient and can conclude the results as well.
ठीक है सर, थैंक यू। और सर इसमें दूसरा ये है कि पैरालाइज्ड वाली कंडीशंस होती है, लेट सपोज अगर किसी को स्ट्रोक वगैरह होता है, तो सिर्फ हम वहीं पर ही कर सकते हैं, या कुछ जो क्रोनिक कंडीशंस होती है, क्योंकि हमने सिर्फ इलेक्ट्रिकल इम्बैलेंस देखना होता है, तो एग्जैक्टली हम इसका अंदाजा लगा सकते हैं। क्योंकि अगर फॉर एग्जाम्पल किसी की कंडीशन वर्स होती जा रही है, तो इस टेस्ट को रिपीट कराने की तो जरूरत नहीं ना पड़ती, या हमें लगता है कि इसको रिपीट करा सकते हैं हम?
Okay, as regard with the NCS and EMG, first of all, we should clear that it is a test for the peripheral nervous system. In the peripheral nervous systems, as I have mentioned, the nerves, we can check the peripheral nerves which are coming from the spinal cord, like brachial plexus. Brachial plexus include the nerves which can be assessed are the musculocutaneous, axillary, then median, ulnar, radial in the upper limb, and in the lower limb, lumbosacral plexus like sciatic via tibial nerve, peroneal nerve, and the femoral nerve, and then sural sensory in the lower limb, saphenous sensory, and then the superficial peroneal. And in the upper limb, as I have mentioned, a lot of the nerves of the sensory that are the digital branches and the radial, dorsal nerve cutaneous, and the medial lateral antebrachial. So, first answer is that it is primarily advised for the peripheral nerve injuries, then mononeuropathies, and the we can say focal or the local trauma site assessment. The where is the site of nerve injury above or below that site of injury, or like in the gunshot, or like in the stab wound, or like in some crush injuries, which part of the nerve is intact, or which on how much is it is damaged. Second, in when we are discussing the stroke patient, stroke is upper motor neuron lesion, as we see. That is a higher mental function abnormality. That is a cortex involved. Some tests can be done, like facial nerve testing, trigeminal nerve testing, sensory, and then through EMG, then we can check the hypoglossal nerve testing. So, when we are discussing the deteriorating condition through the peripheral nerve disease, yes, it can be repeated after 6 to 8 weeks of the first test, so that in that time a nerve healing respond to therapy or comes towards the reinnervation. And if it is not coming, then in the second test the condition will be static. And if in the second test it is uh, compared with the first one, then you can see that there the increment in the term of amplitude, and there is a shortening of the latencies which were prolonged earlier, which is a sign of recovery. So first, it is advised for the peripheral nerve injuries. Peripheral nerve injuries, like I can say, gunshot injury or stab wound injury, or other condition like the mononeuropathies like carpal tunnel syndrome, or radial neuropathy, or sciatic neuropathy. These are the mononeuropathies we are sharing, like the foot drop condition that can be peripherally assessed. These are very helpful in diagnosing these peripheral nerve injuries. And other condition like the neuropathies, as I stated, the diabetic neuropathy or other neuropathic condition, compression neuropathy as we are saying. And in other condition like we have syndromes, Guillain-Barré syndrome, as usually said, that the GBS or the Guillain-Barré syndrome. That is a Guillain-Barré syndrome in its center as well. So we have the different diseases protocols, and we should have to label that, okay, which you are suspecting. You are suspecting a myopathy, then you should query the myopathy there, so that while the EMG and NCS is being tested, this extra question should be addressed as well.
सर
So
बर्न
differential
पेशेंट में
diagnosis.
हम कर सकते हैं?
Yes, sir.
बर्न का अगर पेशेंट है, चाहे सुपरफिशियल बर्न हो या डीप बर्न हो, तो
Yeah,
जब
yeah.
हम उसको गाइड करते हैं तो वो करवा सकते हैं उसको?
Yes, we can, if the skin is available to place the electrode, that can be tested. And on the burn patient, for either it is a superficial or the deep, we can check the electrical signals which are coming from the nerve, and nerve should be intact. There shouldn't be an open wound. That can be tested, and we have tested the burn patient as well to check the integrity of the nerve which are coming towards the hands or the legs. That can be tested.
सर जी, कॉन्ट्राइंडिकेशन इन टेस्ट की क्या होगी?
As regard with the contraindications, uh, except where there is a nerve injury chances, like when we do the EMG, it can hurt the nerve. Therefore, only a trained personnel can do this test. Otherwise, there is no contraindication in this, because we do perform procedure of a 1 day baby to a 99 years old person without any we can say the red flag. There is a no adverse effect of this condition, except that uh, after EMG, the CPK is raised somehow, but it is raised for due to the breakdown of some muscle tissue when we put the needle into the muscles. That is after 1 or 2 weeks that become normal as well. So there is a no absolute contraindication for this.
सर फोबिया वगैरह, अगर एंड सीजर्स हैं किसी को, या किसी को फोबिया है नीडल्स वगैरह से, तो वो क्या उसकी कॉन्ट्राइंडिकेशन में आएगा?
Sir, I think it is a not a contraindication, but for the safe side, the patient should be counseled before this, and both procedures are explained to the patient, because some patient are very scared of crud, because it is coming from the machine, and they might understand that that is electrical shock, but it is a millivolt into, I think we can say, as we are producing from our battery cell. So it is equivalent to that battery cells potentials that we are giving to our nerves. But as it is coming from a concentrated source, or we can say the local source, we give it a very high, that it is a very electrical shock condition, and patient feels very scary. But that phobia is not a contraindication. The physician should understand this condition. They can go for just NCS as well to check the
मतलब
nervous.
सर इन शॉर्ट ये है कि इनकी जो करंट वगैरह होती है वो इतना, लाइक प्रेगनेंसी वगैरह में भी हम दे सकते हैं, सेफ है बिल्कुल?
That's very safe. There is a no, even
ओपन वूंड
this
वगैरह पे भी
can
दे
be,
सकते हैं?
no, not on the open wound. The surface should be clean, at least enclosed. It should not be the lacerated one, because of the contamination of the electrodes as well. Therefore, it is avoided. And in case of that is, I think I missed the point, that that can be given, electrical current stimulation can be given to the even the cardiac patient with the safe mode of their pacemakers. And we have done that patients, that the patient's cardiac pacemaker is on the safe mode, we can do the NCS. That was contraindication. If it is not on the safe mode, that can, you can say that, initiate the electrical activity, or that can increase the electrical activity, interfere with the pacemaker.
ओके सर, थैंक यू सो मच सर। कुछ क्वेश्चन जो है बार बार रिपीट हो रहे हैं, जैसे आयशा आबद का मेरे ख्याल से क्वेश्चन है कि वो पूछना चाह रही हैं कि इनकी एनसीएस कहाँ पर परफॉर्म करेंगे, तो इसका आंसर आयशा सर सेशन में ऑलरेडी दे चुके हैं, और इनकी रिकॉर्डिंग मैं आप लोगों को प्रोवाइड करूंगा, तो आप उनको सुन लीजिएगा। दूसरा सवाल था कि इसकी कॉन्ट्राइंडिकेशन, तो कॉन्ट्राइंडिकेशन भी सर बता चुके हैं कि ऐसा कोई नहीं है। और उसके बाद नेक्स्ट क्वेश्चन है कि साइड इफेक्ट्स क्या होंगे, तो साइड इफेक्ट ओपन वुंड के ऊपर तो जिस तरह सर ऑलरेडी जवाब दे चुके हैं, जो ओपन वुंड में तो हम अप्लाई नहीं करेंगे, जो जख्म है या जो स्किन है वो क्लोज होनी चाहिए और सेफ्टी मेजर के साथ दे सकते हैं, लेकिन उसके ऐसा कोई साइड इफेक्ट नहीं है। और प्रेगनेंसी के ऊपर है तो प्रेगनेंसी भी बिल्कुल सेफ है। तो थैंक यू सो मच सर। मैं बस आपको 2 मिनट लूंगा और गाइस आई विल जस्ट टेक हार्डली 2 मिनट्स मोर फॉर सम अनाउंसमेंट। पहली तो अनाउंसमेंट ये है कि आपको रिकॉर्डिंग जो है प्रोवाइड कर दी जाएगी और इसको 1-2 दिन में मैं आपकी रिकॉर्डिंग प्रोवाइड कर दूंगा। उसका एक्सेस सिर्फ रजिस्टर्ड पार्टिसिपेंट के पास होगा और वो कभी भी इस सेशन को गो थ्रू कर सकते हैं। नेक्स्ट ये कि आप लोगों को ई सर्टिफिकेट मिलेगा जिसमें टीम में डॉक्टर फिकार वगैरह आपसे कांटेक्ट करेंगे, आपसे नाम ईमेल वगैरह सब पूछे जाएंगे और आपको सबको 1-2 दिन में ऑफिशियल ईमेल के थ्रू सर्टिफिकेट प्रोवाइड कर दीजिएगा। तीसरी अनाउंसमेंट ये है कि नेक्स्ट सेशन हमारा नेक्स्ट वीक ही होगा बिल्कुल, और वो भी डेफिनेटली हर सेशन मेरे ऑनलाइन हमारे जो है ऑनलाइन ही होते हैं। उसकी अनाउंसमेंट भी आपको ग्रुप के थ्रू ही मिल जाएगी। इसके बाद कुछ मैं आपके 2 मिनट हार्डली लूंगा रिगार्डिंग द अनाउंसमेंट। अगर आप पास सेशंस को हमारे गो थ्रू करना चाहें तो वो भी यहाँ पर मौजूद हैं और मैं आपको थोड़ा बहुत देता हूँ। ये हमारे फर्स्ट सेशन था, सेकंड ये लास्ट सेशन थे जो हम ऑलरेडी कंडक्ट कर चुके हैं। इनमें से कोई भी टॉपिक जो आप लोगों को ठीक लगे, आप लोग ज्वाइन करना चाहते हो तो उसकी वही जो है थोड़ी बहुत फीस है वो हमसे लेंगे। कुछ और अनाउंसमेंट थी, सीएमटी का ये जो रिहैब एक्सपर्ट पैनल है ये चौथा प्रोजेक्ट है। इसके अलावा जो मेरे प्रोजेक्ट्स हैं सीएमटी के वो मैं आपको मुतारफ करूंगा। इसके अलावा मेरा एक और प्रोजेक्ट है सीएमटी एकेडमी फॉर द डिफरेंट लाइसेंस एग्जामिनेशन। उसमें भी उसमें क्या होता है कि जो भी गल्फ कंट्रीज के लाइसेंस के एग्जामिनेशन है उनकी मैं प्रिपरेशन कराता हूँ। और बाय द ब्लेस स्पेशली गल्फ कंट्रीज में अराउंड अबाउट 50 बच्चा जो फिजियोथेरेपिस्ट है जिन्होंने ज्वाइन किया था उन्होंने अटेम्प्ट भी किया है और उन सक्सेसफुली उन्होंने क्लियर भी किया हुआ है। गल्फ कंट्रीज में आपके सऊदी, दुबई, कतर, बहरीन, ओमान, इन सब की मैं प्रिपरेशन जो है वो करवा रहा हूँ। और मेरी एमसीक्यू की बुक भी है जो कि रिसेंटली आफ्टर ईद जो है वो हम उनको लॉन्च भी करेंगे। ये बैच आप किसी भी टाइम ज्वाइन कर सकते हो। इसमें सिर्फ हम आपको क्वेश्चंस प्रोवाइड नहीं करता, इसमें हम आपकी एक्सप्लेनेशन भी देते हैं, टॉपिक्स भी पढ़ाते हैं ताकि आपका थोड़ा सा कॉन्सेप्ट भी क्लियर हो सके। मजीद इन्फॉर्मेशन के लिए आप सीएमटी या हमारे व्हाट्सएप ग्रुप के थ्रू इनको ज्वाइन कर सकते हो, ना कि सिर्फ पेपर के हवाले से बट अदर कंसल्टेशन। हमारे पास डिफरेंट गल्फ कंट्रीज के जो है कंसल्टेंट भी मौजूद हैं, लाइक जॉब रिक्रूटमेंट या डेटा फ्लो वगैरह, उसके हवाले से भी आपको इन्फॉर्मेशन जो है मिल जाएगी। एक प्रोजेक्ट मेरा ये है। इसके अलावा एक और प्रोजेक्ट है, ये आपके सामने अबू धाबी का है। अबू धाबी का आपको थोड़ा सा मैं इलम देता हुआ चलूं कि डीएचए और गल्फ कंट्रीज से अबू धाबी काफी हटके है, क्योंकि अबू धाबी के जो क्वेश्चंस वगैरह आ रहे होते हैं वो आते हैं स्कोर बिल्डर की बुक से। और आपको पता होगा स्कोर बिल्डर्स की बुक जो है वो एनपीटी नेशनल फिजिकल थेरेपी एग्जामिनेशन के लिए भी यूज होती है। तो डीएचए के बाकी गल्फ कंट्रीज एक तरफ, अबू धाबी का जो पेपर होता है वो एक तरफ, उसमें अलग क्लिनिकल सिनेरियो बेस्ड क्वेश्चन होते हैं, उसकी भी प्रिपरेशन की जो है हम बैच लॉन्च कर चुके हैं। ठीक है, ये हमारा 100% जो सक्सेस रेशियो है, इन लोगों ने ज्वाइन किया और बाय द ब्लेस सक्सेसफुली दे क्लियर देयर एग्जामिनेशन इन द फर्स्ट अटेम्प्ट। तो स्टिल वी आर मूविंग विद द 100% सक्सेस रेशियो। और बाकी कंट्रीज के ऊपर भी मेरे डिफरेंट वेबिनार्स हैं जो मेरे यूट्यूब चैनल पे अपलोडेड है। एज यू कैन सी आपके पिक्चर आपको डिस्प्ले हो रही होगी, ओमान, चाइना, इनके हवाले से इनके भी जो वेबिनार्स हैं वो मेरे यूट्यूब चैनल पे अपलोडेड है। देयर आर नो चार्जेस, आप उनको वॉच करें, उनको गो थ्रू करें। उनकी कंसल्टेशन के लिए भी आपको कोई इन्फॉर्मेशन चाहिए, यू आर वेलकम, यू कैन आस्क फॉर द इन्फॉर्मेशन। और ये मेरे दूसरे प्रोजेक्ट्स हैं सीएमटी की तरफ से जो डिप्लोमा इन मैनुअल थेरेपी, सर्टिफिकेट इन मैनुअल थेरेपी विद सीपीडीआरस। मैं सीपीडीआरस भी प्रोवाइड करता हूँ। आपको पता होगा सीपीडीआरस की वर्क क्या है। जब आप इंटरनेशनल लेवल पे जाते हो तो क्लिनिकल आवर्स को मैनेज करने के लिए, मेंटेन करने के लिए आपको उधर एनुअली सीपीडीआरस दिखाना जरूरी पड़ता है। जो बच्चा, जो भी फिजियोथेरेपिस्ट बाहर जा रहा है, बाहर के लिए अप्लाई कर रहा है या बाहर पे ऑलरेडी जॉब कर रहा है, उनको सीपीडीआरस की वर्क की पता होगी। तो इनकी इन्फॉर्मेशन भी आपको सीएमटी पेज से जो है वो इजीली मिल जाएगी। ये मेरी दोनों बुक्स हैं। तीसरी बुक मेरी एमसीक्यू पर है। ये मैनुअल थेरेपी की वॉल्यूम 1 की बुक है जो कि आउट ऑफ स्टॉक है, अवेलेबल नहीं है। लेकिन वॉल्यूम 2 जो आपके सामने राइट साइड पे है ये स्टिल अवेलेबल है। और एमसीक्यू बुक आफ्टर द ईद बाय आई विश कि मैं इसको जो है वो लॉन्च करूंगा। और रिहैब एक्सपर्ट पैनल आप लोग ज्वाइन कर सकते हो, जो ये मेरा चौथा प्रोजेक्ट है जिसके प्लेटफॉर्म के थ्रू आप हमें लिंकअप हैं, इनको आप ज्वाइन कर सकते हो एज ए पार्टिसिपेंट, एज ए एम्बेसडर। एज ए एम्बेसडर इसके कुछ चार्जेस हैं। एज ए पार्टिसिपेंट यू कैन ज्वाइन, जिसके आपको ऑलरेडी इन्फॉर्मेशन मिल चुकी है। बट आप इसको एज ए स्पीकर भी ज्वाइन कर सकते हो, लेकिन सबकी एक रिक्वायरमेंट है, आप व्हाट्सएप ग्रुप के थ्रू टच में रहिएगा, हम आपको जो है वो इन्फॉर्मेशन दे देंगे। लास्ट बट नॉट लीस्ट, ये एक ऑस्ट्रेलियन जेम्स स्पीकर हम बुला रहे हैं सीएमटी कोलैबोरेशन के साथ, हम उनको बुला रहे हैं। इस्लामाबाद में आ रहा है जुलाई में और सितंबर में आ रहा है कराची। इनके बारे में बस इतना बता चलूं, ये वैसे तो एक जनरल मैनुअल थेरेपी का एक वर्कशॉप है, लेकिन ये ऑस्ट्रेलिया के रिक्रूटर है। जो बच्चा, जो फिजियोथेरेपिस्ट ऑस्ट्रेलिया की तरफ मूव ऑन करना चाह रहा है तो उन सबको पता होगा कि एक रिक्रूटमेंट रिक्वायर्ड होती है। तो इनके जितने भी रिकमेंडेड फिजियोथेरेपिस्ट हैं ऑल ओवर द वर्ल्ड, उनको जॉब भी लगी, उनको इन्होंने जिनको रिकमेंड करता है। बहरहाल तो ये रिक्रूटर भी है और कंसल्टेंट भी है, नॉट ओनली टॉकिंग अबाउट। तो आप में से किसी भी किस्म की आपको इन्फॉर्मेशन चाहिए, आप व्हाट्सएप ग्रुप के थ्रू मुझसे रब्ता कर सकते हैं, टीम के थ्रू रब्ता कर सकते हैं। तो थैंक यू सो मच ऑल द गाइस फॉर ज्वाइनिंग and see you next week, inshallah, with the new topic. Once again, thank you so much, Dr. Chaman, for sharing your information with us. Sir, आपकी तरफ से क्लोजिंग रिमार्क, इसके बाद मैं जो है वो सेशन को जो है खत्म कर दूंगा. सर, इट्स ओवर टू यू. आप बस क्लोजिंग रिमार्क्स करें, फिर मैं मीट, क्योंकि सर अफ्तार भी है बच्चों के हवाले से.
थैंक यू सर, इट वाज अ नाइस सेशन. अभी एक और क्वेश्चन दोस्त ने पूछा है कि ये सर्टिफिकेशन सर्टिफिकेशन एक्चुअली इसमें एमएस करवा रहे थे पहले इसरा यूनिवर्सिटी, जो कि MSDN डायग्नोस्टिक इलेक्ट्रोन्यूरोफिजियोलॉजी प्रोग्राम था. बट अनफॉर्चुनेटली दे हैवंट स्टार्टेड एनी बैच, बिकॉज कि उसमें फिजियोथेरेपिस्ट की तरफ से कोई पार्टिसिपेशन नहीं की गई या कोई विलिंगली नहीं हुए. लेकिन ये पाकिस्तान में MS प्रोग्राम इसके लिए लॉन्च हुआ था, और लेकिन वो स्टार्ट नहीं हो सका. फॉरेन कंट्रीज में इसके ऊपर जो है वो सर्टिफिकेशंस और पोस्ट ग्रेजुएट डिप्लोमास अवेलेबल हैं, जो कि फिजियोथेरेपिस्ट कर सकते हैं. डिग्री प्रोग्राम्स भी हैं. PhD न्यूरोफिजियोलॉजी भी अवेलेबल है, दैट कैन बी a very supreme degree as well. And I shall thank Dr. Dilip and his team CMT for inviting me on this session, and I'm humble for this session as well. Thank you for joining. Allah Hafiz.
Thank you, everyone. Thank you, Sir Chaman. Special thanks to Sir Chaman, Dr. Iftikhar, panelist or co-founder of Rehab Expert Panel, and all the respected participants for your time. And बस दोनों अनाउंसमेंट मैं कर चुका हूँ. आपको सर्टिफिकेट के लिए भी टीम राब्ता करेगी, और आपको सेशन की रिकॉर्डिंग कल तक मिल जाएगी. ठीक हो गया. थैंक यू एवरीवन. आपको किसी भी किस्म की इंफॉर्मेशन चाहिए तो सेंटर ऑफ मेनल थेरेपी फेसबुक पे लिखें, गूगल पे लिखें, और अपना जो भी फीडबैक है वो जरूर पुट कीजिएगा, और व्हाट्सएप ग्रुप में टच में रहिएगा जब तक आपको सर्टिफिकेट मिल जाए. Thank you, everyone. Stay blessed.